Yeah, let's not be personally ready for some heart failure, but professionally ready to learn about heart failure. So heart failure and dysrhythmias, we've basically been working our way up. We started with sort of angina, where we had atherosclerotic plaque, we had angina and chest pain, we had myocardial infarction, cardiomyopathy, and now we're going to work our way up to heart failure. So there was some linear logic there. I'll show you a case in which it may not be that linear, but we'll get to it. So heart failure means your heart cannot sufficiently pump blood forward for some reason, right? Usually it's going to be secondary to, okay, you had a myocardial infarction or a series of myocardial infarctions and you damaged a lot of the tissue on your heart. Or you have that stiffening effect, or you have cardiomegaly, all of which would cause an inability to push blood forward, right? It is increasing in incidence. Again, cardiovascular disease in general is increasing in incidence, and also lifespans are simply longer. So we have a longer lifespan in which to accumulate these diseases of aging, essentially. What we're going to see with heart failure, you're going to see this word congestion quite a bit, congestion. With heart failure, there can be systolic dysfunction, diastolic dysfunction, and inability to contract, and also potentially an inability to relax, or yeah, and that's not really the part we're focusing on. We're going to focus on the backwards and forwards effects and the compensatory mechanisms. So when your heart is not sufficiently pumping things forward, that's an issue related to cardiac output. I keep coming back to this phrase cardiac output for a very, very good reason. I was previously finding that people were finishing my courses without fully understanding cardiac output, so I am reinforcing that here so that you have it when you get to med-surg when it's even more important. So you're in heart failure, cardiac output is low. You're going to have a decreased GFR, glomerular filtration rate. Remember, that's dependent on hydrostatic pressure and the glomerulus. You thought that kidney day was useless? You were wrong. You did need to know everything about kidneys, and you still need to know everything about kidneys. So here you are in your kidneys with a low GFR, and you know that low blood pressure is going to activate which pathway? RAS, renin-angiotensin-aldosterone, is going to be activated in response to the lower blood pressure of low cardiac output. Baroreceptors are going to detect that. Your brain's going to stimulate your sympathetic nervous system. We were just talking about a blood pressure medication that acts on the sympathetic nervous system, right? So your sympathetic nervous system increases your epinephrine, your norepinephrine, binding to noradrenergic receptors, and that's going to attempt to increase your heart rate and contractility. So any cells that are working will increase their contractility and the strength of their contraction, right? As the walls of the ventricles experience tension, you can experience hypertrophy. So even if you didn't have a cardiomegaly before, now you're going to have a cardiomegaly. And all of this is going to attempt to compensate for the lack of ability that your heart has. You are going to increase your cardiac output. Part of that is going to be literally your heart's beating faster. Your heart that does not work is beating faster, right? It's a problem itself. So always be considering cause and effect. What was the hypertrophy caused by? What was the elevated heart rate caused by? All these signs and symptoms, they're usually the compensatory mechanisms. It's not that the heart cells itself caused it, it's that the compensatory mechanisms caused it, right? So your clinical manifestations are going to be dependent on whether it's the right side of the heart that failed or the left side of the heart that failed, and that's what takes us straight back to the week 1 worksheet where we had this image here of the arrows leading to the heart, right side of the heart, and away from the right side of the heart, and an arrow coming to the left side of the heart and going away from the left side of the heart. It goes straight back to this concept. This gets you everything. Now, as I understand it, as future nurses, you're not going to need to categorize it as left versus right-sided heart failure. All the case studies I've seen in nursing simply address heart failure. And us doing this left versus right is just sort of a nitty-gritty physiology thing. But I think it's still worthwhile for understanding what's going on. How there's going to be 2 different sort of manifestations, different but complementary. There's always going to be backwards failure and forwards failure, and hopefully we've utilized this enough that this is just going to make sense. Backwards failure means blood is going to pool upstream of the injured part of the heart, backwards from the injured part of the heart. And downstream, forwards from the injury to the heart, you're going to have a lack of blood flow. So you have forwards effects and you have backwards effects. You have downstream effects, you have upstream effects. I'm the one adding the stream terminology. Medicine does not use the stream terminology. If you hate streams and you don't understand upstream, downstream, throw it out the window. Just use backwards effects, forward effects. Those are the clinical terms. So backward failure is always going to be congestion of blood. Forward failure is always going to be a lack of blood flow, ischemia, and so forth. So we'll start with left ventricular failure, left-sided heart failure. Backwards from the left side of the heart is what? Your lungs. So you're going to have blood pooling in the lungs when you have left-sided heart failure. And that's going to lead to a big chunk of your signs and symptoms of left-sided heart failure. So you're going to have pulmonary congestion. The blood is pooling in the blood vessels of the lungs. Your lungs are vascular, lots of capillary beds, because that's where gas exchange occurs, right? And again, because that's where gas exchange occurs, you're going to have some cyanosis. Your oxygenation is going to be impacted by this. Forward effects are going to be reduced cardiac output, which is going to lead to increased RAS activation, and decreased tissue perfusion, which is also supporting your cyanosis. This is from a different textbook. This is the image from your textbook. Let's take a moment to appreciate that. I think I understand what they were aiming for. I'll show you the other one for right-sided heart failure. I get what they were aiming for, kind of. I don't think they did a good job. I don't think they were successful in conveying what's... Yeah, tripod position and, yeah, venous stasis, absolutely. But it's still not well illustrated. You don't see that image and immediately think of heart failure, in my opinion. So I took these images from somewhere else entirely. I think it was something like Pathophysiology Made Incredibly Easy or something along those lines, or Made Incredibly Visual might have been the book I took it from. I think it's a better sort of visual cue for this type of heart failure. Okay, because you have pulmonary congestion, there's going to be cough, crackle, wheezes, potentially blood-tinged sputum, tachypnea, and again, try to do a cause and effect thing and make those things make sense. They should all make sense for blood simply pooling in that area. When we have a lot of blood pooling, we're also going to have sort of an edema going on. The fluid is going to shift out of the vascular pool and into the interstitial space, which in your lungs is your alveoli. And that's important. And again, you've got your compensatory mechanism of tachycardia. Confusion as well, which would make a lot of sense if you're hypoxic. Now on to right-sided heart failure. Again, you're going to have backwards effects and forwards effects. What's backwards from your heart? Your body. What's forwards from your heart? Your lungs. So you're going to have blood pooling in your body. You're going to have edema in your extremities, in your lungs. Oh yeah, did I point that out yet? No, it's coming out. Never mind. Okay, you have all the blood pooling in your body, and it's going to pool in your extremities. It's going to pool in your abdominal cavity. Your peritoneal cavity may fill with fluid. So systemic congestion. Forward effects are decreased tissue perfusion. Now you're not sending blood to your lungs for oxygenation, right? So it can't return to the left side of your heart, so it can't be ejected. With this RAS activation, you're gonna be retaining fluid. Remember, part of this is about where fluid is shifting to. We are going to very soon be going into following the fluid. Where's the fluid? What compartment's is it in? When you're losing fluid into the interstitial compartment, fluid retention is probably not going to be your friend. Has anybody ever seen anybody with heart failure and you kind of poke at their legs and what happens? Yeah, yeah. Okay, so that's what we see here. We've got some enlarged ankles, feet, extremities. When we have fluid buildup in the peritoneal cavity, we call that ascites. We will see ascites again. I quite promise that there will be ascites again. Fatigue, a distended jugular vein. Again, this may be something that is there all the time, or sometimes that's the one we were talking about earlier where you compress the liver, and it's actually going to cause your jugular veins to distend. Yeah, I agree. If you have fluid buildup in your peritoneal cavity, you may not want to eat. You probably don't feel good, right? So anorexia, complaints of GI distress because the fluid shift is off in your peritoneum. Yeah. Now here's another thing about heart failure. I think it's coming up here in a second if I haven't already skipped over it. A sided heart failure ultimately is going to lead the other side of the heart to fail. Now that other half of the pump is working extra hard, it's going to fail ultimately. So unilateral heart failure is going to lead to total heart failure, but it's progressive. As I mentioned earlier, you can have heart failure for weeks, you can have heart failure for months, you can have heart failure for years. I know, it is crazy. Okay, I have nothing to add to faces. Here's a little bit about treatments. This will just overlap with your pharmacology. And we have drugs to improve cardiac output. We have drugs to inhibit the sympathetic nervous system. So who knows the one drug that every heart failure patient's on? Lasix, that's the one. Somebody always knows it. Every cohort has always had somebody shout Lasix in response to that. What is Lasix? Yeah, it's a diuretic. It makes you pee, as I understand it. And you guys, I think, are just being more detailed than I am about that, unless I'm contradicting anyone. No? Okay. Yeah, it just makes you pee. So that fluid shift that you're experiencing, we're going to help get rid of that excess fluid volume. We have, let's see, ACE inhibitors, for example, reduce the effects of angiotensin II. This is, again, why you need that whole RAS pathway. And pacemakers. We are going to see in a minute how having part of the heart muscle damaged can potentially contribute to an arrhythmia. So we did our whole sequence of things, and now we've got arrhythmias in there too for our timeline. How are arrhythmias going to work into this? So let's go look at some arrhythmias. We've got two really good videos to watch. We're going to watch living arrhythmias, and then after that, we're also going to watch a really great video about reentry circuits. These are other people's YouTube videos, so I'm not going to put them on the recording because my recording is a YouTube video and I'm not trying to plagiarize here, but I will refer to them. So let's go ahead and watch a couple of those now that we know enough about heart failure to understand this. Let's actually do reentry circuits first video and then living arrhythmias, and I'm going to pause the recording. We just watched on YouTube was from UBC Medical. It was a description of reentry circuits as described by using a metaphor of roads. So what he was describing, let me put it in strictly clinical terms for the sake of the recording before we move forward. He was describing the activity of action potentials traveling through the electrical conducting system of the heart. He described that there's multiple pathways. There's a quick pathway and a slow pathway. And usually in a normal, healthy heart, they will coexist with each other, and when action potentials run into each other, just cancel each other out. And so your normal physiological heart rate is determined by autonomic innervation of your autorhythmic cells at the SA and the AV node. So that's normal. So we had the initiation of a reentry circuit when we had a premature beat. We need to have something inappropriately triggered in the electrical conducting pathway, which is our next concept. We had an immature beat that went through the fast and slow circuits, kicked up a refractory period, and made it impossible for your physiological, your SA node, your autonomic nervous system, to control your heartbeat. Instead, the action potential is simply propagating again and again through the reentry circuit and at top speed. right? It's going as fast as it possibly can, and any normal heartbeat is just going to hit a refractory period and be unable to take control. And that gave us our explanation for what our defibrillators are doing. So our defibrillators, they're not starting your heart. They're stopping your heart. They're causing an action potential throughout your heart that kicks up a refractory period throughout it to short circuit, literally, the reentry circuit. And now your SA node can fire a physiological beat again, and that, if successful, will reinitiate your physiological heartbeat. Turning your computer off and then on again. Absolutely. I feel like you deserve a squishy for your participation today. You've been on fire. Okay. So is that more or less making sense? Yeah, and that's a miracle. That video is a miracle. I had no clue the first couple times I taught this. I was just like, eh. But then I found that video and, oh, thank goodness. So here's a mechanism of a reentry circuit. One thing that could cause a reentry circuit, a premature heartbeat, would be a block, an area of block. Part of this pathway of this electrical conducting system is blocked. And that could be because of maybe myocardial damage. Maybe some of those myocardiocytes are dead from any one of the mechanisms we've already seen today. So this is another thing that's going to go on your timeline. This is the sketchiest one to put on your timeline, though. If you're in emergency medicine, you know that you don't necessarily have to have a history of myocardial infarction to have a dysrhythmia. However, we're going to pretend that they're going to interact with each other in a linear fashion for the sake of writing our timeline today. So we can have blocks anywhere along our electrical conducting pathway. We can have a block between the atria and the ventricles, and those will be by degrees. You can have a first-degree block, which may actually be subtle. A first-degree block would change the interaction of the atria contracting to the ventricle contracting, but it may not be something super noticeable, at least not in a clinically obvious way. Then there's second-degree blocks and third-degree blocks. Now that we have this vocabulary established, we're going to go ahead and pause again to watch the Living Arrhythmias video, and suddenly it's going to make a lot more sense than it did in ANP2. So we just watched the Living Arrhythmias, and we saw sort of what the heart looks like in the form of some interpretive dance, some absolutely wonderful interpretive dance. We saw the type 1 block between the AV, and it just kind of slowed things down between the atrium and ventricles, whereas the type 2, we started having the change in rate between the atria and ventricles. By the time we got to the type 3, the third degree block, rather, I should say, the time we got to third degree block, we were having multiple atrial contractions before we were having ventricular contractions, which brings us to how we're going to start interpreting the ECG patterns in terms of the dysrhythmias, right? So again, what was the first wave in the sequence? Right there, the little one? P wave, and that represented what? Atrial depolarization, therefore atrial contraction. So if you're having atrial fibrillation, what's that going to look like? What are you going to have a lot of waves of? P wave, P wave, P wave, P wave, and then maybe a QRS complex, depending on how severe this is, right? If you had ventricular tachycardia, what are you going to see a lot of? QRS complexes, excellent. And that's actually as far as we're going in here in this class. As I understand it, again, talking to clinicians about interpreting ECG patterns, if there's a bunch of waves, looking crazy, you're not always going to know that it's a P wave or a QRS complex. They're not going to be shaped that way when they're abnormal. So we're doing this in a purely hypothetical way. You know that it's atrial fibrillation, therefore you know it's P waves. You know it's ventricular fibrillation, therefore you know it's QRS complexes. We're kind of working backwards just to connect those ideas in here. Karen Riley's going to do more with ECG with you, but this is just foundation. Sound good to everyone? Sounds good. Okay, so it used to be on the worksheet. I may have changed the formatting. I used to ask you For an example of something that would alter a P wave, something that would alter a QRS complex, something that would alter a T wave. So we've seen a number of things already that involve changes to the ECG, right? We've already seen, what are the signs for myocardial infarction? And the ECG, how's that going to look? Yeah. STEMI, elevated ST segment. Excellent, good job. And then what was the other one that's common for MI? Yeah, the one that's not a STEMI. Inverted T wave. Yeah. Okay. So I'll hold you to understanding atrial flutter, that these are P waves. And atrial fibrillation, you can see the change there. And QRS complexes for ventricles, full stop. That's it. We finished. That's it. We do worry about that irregular rhythm causing thrombi, throwing clots. That's one danger of this, in addition to all the other dangers of dysrhythmias. And we're done. Any questions before I turn off the recording? Go for it. Yeah, I don't answer those questions. Go to your learning objectives and see if there's anything on the learning objectives. Yeah. That's how my learning objectives work. I underline the ones I want to test on and I ask questions about them. So yeah, know those worksheets. I agree. Especially this quarter because I've updated them for the new exams. So. Okay. Questions? Any more questions before I turn it off? Thus endeth the recording.